Hey, what's up guys? I just wanted to make a really quick video before the interview just to explain a few little things. One, this interview is kind of centered around this concept of loop gain. A lot of you guys are going to not have much experience with this idea, but just think of it as respiratory control. That is the control of breathing. This whole interview is kind of centered around it. This doctor slash professor hyper specializes in this area, which is sort of a missing tool in the belt of a lot of other sleep physicians. You can think of loop gain slash respiratory control as a good analogy is like a thermostat. Imagine you're trying to keep a room at about 20 degrees. And imagine the room goes down to 19.999999, and that's enough to turn the heater on. Well, obviously the heater's not gonna stop right at 20 if it's starting at 19.999999, right? It's gonna overshoot it. And then it's gonna react to that and undershoot it, and so on and so forth. And it starts this process. And so another way to think of it is kind of just like the sensitivity to the CO2 levels or the sensitivity to breathing disturbances. Very small breathing disturbances can cause large reactions with some people and very small or no reactions with others. Keep in mind that I wasn't actually going to even make this a video. I was just going to ask him questions so that I could help and relay the answers to some of the people who I'm working with. But last second I was like, you know what? Let's just record it and see what happens. And to be honest, the quality seems good enough. If it's not, there's redeeming subtitles at the bottom of the video, which I meticulously put in. So I hope you appreciate it. I learned a lot. I hope you learn a lot. This guy is a wealth of information. I hope to have him on again. I hope to have other titans in sleep medicine on as well. Let me know who you want me to talk to you. We're not gonna hit the ball short around here. Whoever you think it is, I'll do my best to get him on or her on. And yeah, we're gonna cure you guys. So we need these people on our side. Anyways, I'll stop there. Enjoy the show. If you don't understand something, this guy, you know, he's been in this field for a very long time. He name drops a lot of acronyms and organizations and so on. Just pause the video and just go look it up. I was gonna put that everywhere, but that's just gonna, I think, disrupt a lot of viewers. So if you're like, what the hell is this guy talking about? Take a couple minutes and go look it up and you'll figure it out. And then everything will kind of piece together, I think, a little bit better. You guys know I don't like to be super transactional, but if you guys subscribe and like this video, it helps get to other people, which means it helps literally, hopefully save other people. You know, the impact is essentially immeasurable. It's a very small effort on your guys' behalf. So just please subscribe, please like, and enjoy the video, okay? If you're interested in a one-on-one conversation with me, where we can look over your data or discuss anything sleep, I've left a link in the description.
How can I help you?
Oh, so, you know, I gave you a little bit of background, but basically I just try my best to get patients to where they need to be and to try to help them troubleshoot their PAP settings. And yeah, I keep running into similar problems. If bi-level doesn't work, PAP doesn't work, APAP doesn't work. A lot of these patients seem to have what I believe is like short cycle periodic breathing that's not being detected as anything. And that's kind of where I draw the line. And I started looking into, well, some of your talks and some of the literature which you've produced. But it's still not, I still have so many questions, and I just feel like I'm in a position where I can't fully resolve their issues. And if that's the case, it'd be nice to be able to send them to people who would be able to help them with their next steps.
So what do you do?
I just, you know, I went through a horror show of trying to figure out what was wrong with me, which lasted probably 6 years. I'm from Canada, and I
So
eventually,
you're based in Canada?
I actually live in Mexico, but I'm Canadian,
Okay.
and basically, I know I was gaslit and dismissed and stuff forever in the Canadian medical system, and I finally figured out what was wrong with me after seeing some of the surgeons in California and reading literature and just continuously looking for answers. And I eventually got into helping other patients with troubleshooting their PAP therapy through Oscar, because there's all these forums, and of course we all go there trying to optimize things so that we can get a better quality of life. Eventually you learn how to do it. And then I made a YouTube channel and to explain to people so that they can do it themselves, teach them how to fish, so to say. And I'm just trying to continue in that trajectory. I feel like, well, 98% of sleep medicine seems to be behind the curve, and even at the forefront, there still seems to be an element of incompleteness, and I'm just trying to do what I can to fill in the blanks. And you just came across as someone who is very, very, very knowledgeable on this subject, and I would consider you to be in the vanguard. Not trying to, shower you with compliments or anything, but I have encountered, countless physicians at this point, and some know more than others, and some specialize more with obstructive stuff, and then there's others who specialize more in the loop gain area, and you seem to be that person. And that's also where I would say my greatest gap in understanding is.
Unfortunately, sleep physicians don't spend any time in the sleep lab. It's structured to not be user-friendly in that sense. Bottom line is that you don't get paid for spending any time in the sleep lab at night. The billing code is the same for the sleep study. So, in general, people don't do stuff they don't get paid for. This is true anyway, right? A lawyer doesn't do stuff for fun. Well, they may do stuff for fun, but not, at least for fame, but they need to get one of them anyway. So sleep medicine is mostly full of armchair physicians. They are not bad people, but there isn't a culture of technical expertise in sleep medicine among physicians. There are many technicians who are very good at what they do in terms of getting great signals and understanding the devices and so on. But their medical knowledge is usually not very good. I mean, they're not doctors. They're not trying to be doctors. So the physician has to provide the complementary part. And if they don't spend time in the lab, you simply don't know. Like an interventional cardiologist does not learn what they do or become good at what they do by staying at home. They're in the cath lab doing cath, facing the challenges, coming up with ideas, innovating. That's how cardiac intervention has, developed over the years. And sleep medicine, I started in '96. It was largely CPAP, and if CPAP didn't work, you threw bi-level on them. If that didn't work, and work is anyone's guess what was meant by that time anyway. Maybe you add some oxygen. I mean, people flail around. But now understanding is better, much better. And technology, there are more options technologically. I won't say they are necessarily better, but certainly there are more strings in the instrument of sorts. But the practice has not moved on. The practice has lagged behind. Even those who publish in the area of central sleep apnea, loop gain and such, their clinical services are very prehistoric. So their knowledge and their research is doing well, but is not infecting their patient care, if I may use that phrase. For me, it's just the opposite. I get my ideas from patients and their care, and then I translate that into research. So it's the other way around. So it's more, there's more, interactions. And at this point, it's actually very simple. It's like a language, right? If you know language, you understand what people are talking. If you don't know the language, it doesn't make a difference what other languages you know. You still have to. So I teach in China. I go to China often enough. And, I don't speak Cantonese or Mandarin. Some words I can kind of figure out. But for the most part, until they turn to me and explain in English, I really don't know what they're talking. So for sleep medicine, the language of the signals could as well be Chinese, because the ASM guidelines really don't go beyond a very basic alphabet. But there just are a lot of people in high positions who don't want to rock this boat, keep it very convenient, just blame the patient for lack of success. And I make a lot of my living by just taking care of patients who have failed primary therapy, CPAP or otherwise. And it's usually very obvious why they have failed. loop gain is one of them, but there are other reasons too. But high loop gain is breathing control instability is the most common reason. When someone has tried really hard, now clearly people, they may not be able to try hard if they're too sick. Those are different issues. But if a person really tries very hard with CPAP, mass fittings, retitrations, really try hard, and either they feel worse on it, or they feel they're fighting the pressure, or the machine, of course, shows high residual AHI. And if not, Sleepyhead, Oscar, whichever you use, will show the abnormality. It's almost always breathing control instability. It's like a horse which is bucking, right? I mean, it's hard to hold it down. And we have developed different approaches, all of them biologically fairly logical, oxygen stabilizing CO2 using acetazolamide or Diamox. It's actually very simple if you recognize it. But if you just go by the ASM rules, you can't recognize it. So that's where the problem is. If you're following the guidelines, it doesn't matter how well you follow the guidelines, it doesn't work. So I think the only real solution is awareness of patients. And the way to do that is to be able to look at their raw data through Oscar. And to kind of understand what the squigs mean, basically. And, what is stable breathing, what is unstable breathing, how to recognize obstructive versus more centrally, centralness of the problem, if you wish. And once they recognize that, well, what they can get their physicians to do is limited. Outside, my area of practice here. But they could at least prevent everybody from blaming them, and maybe push their physicians to try to prescribe acetazolamide. I mean, they should take out printouts and show the physician this is what the device is missing, and so on. Because I've been teaching this more phenotype, endotype driven practical sleep medicine since 1998. That's a long time. And I've done presentations at sleep meetings, of course, plenty of publications and whatnot. But as long as the ASM guidelines keep it very simple, that's what people are. So the ASM is not showing any worry about this at all. So it has to go through the patients. And patients have to just, they should be looking at the data just like a diabetic looks at their blood sugar. A diabetic, glucometer, when I was in medical school, there were no glucometers in India. You had to go to the hospital to get a blood sample to know what your sugar was. At home, you could do urine testing using Benedict's reagent, green-blue color, and then you put the urine in it and you heat it on a candle, because if you heat it on anything stronger than that, it'll probably bust the glass, right? And if it turned red, you better go to the hospital because you're in trouble. And it was that crude for a long, long, long time. Now it seems almost quaint. Diabetes management anywhere in the world, except perhaps in some parts of Asia, Africa. But then, apps on the phone are coming into for, figuring out blood sugar and so on. But you would never think of managing blood sugar without being able to track a person at home now. At least you can't manage it well. Until you tracked, you didn't know the dynamics. So patients will have to look at the data themselves. The numbers given by Philips and Respironics and everybody, ResMed, etc. When the residual AHI is high, you better believe it. It means things are really bad. But when it's an intermediate range, when it's 4, 5, 6, 7, 8, you have no idea whether it's 40 or whether it's 5. Because you can just miss stuff completely. I got like 100 snapshots until I stopped collecting them, showing these misses. So yeah, the only solution is to empower the patient with knowledge, with the appropriate knowledge to better understand how well they're doing. It doesn't mean that anyone doing well should not look at the data. They should, but it should just be normalized. It's pity that you have to use freeware to hack into the devices, but that's where it is now. So if you want to do a recording of some kind where we go over Oscar, know how to use Oscar, I can help you do that. It's not. I show my patients every day.
Yeah, so yeah, I mean, I don't know if I communicated in a way that's unclear, but I actually look at Oscar all the time and help patients read the data, but there are some things that I think I alluded to that I don't quite understand. Like, for example, I believe what I'm seeing in some patients' flow rate is short-cycled central like breathing. And my questions to that would be, well, what would be the solution? And two, is that always going to necessarily be disturbing? Is that going to fragment sleep architecture and cause daytime symptoms? Or is some of that harmless?
So I
Obviously,
would say that you can get to stable breathing in patients with somewhat pure OSA in about 95% of the night can be pretty stable. And patients who have non-obstructive mechanisms to their sleep apnea, you can get them to about 90% stable. More than that is really quite hard because the normal transitions of, light, deep, REM, non-REM, and such, the breathing wobbles. So the rest should be stable breathing. Now, symptomatically, some individuals are, even if they have bad apnea, they're not very symptomatic. So they are not good at figuring out, like their symptoms don't correlate with anything you see on the data. But the average person coming to a sleep clinic, they are symptomatic. And the more stable their breathing, the better things are. And breathing is not all. People, about 30–40% of patients, despite pretty good breathing, their sleep is still not great. Now, whether it is just being beaten up for a long time or whether they're just born with light sleep, they often have the sort of comorbid insomnia phenotype. Maybe the insomnia is independent of the apnea, but nevertheless, their sleep is not great. So my philosophy is to try to stabilize what you can find the best you can. So, some elements of cognitive behavioral therapy is always useful. I use sedatives quite a bit for non-REM apnea, not REM apnea, but non-REM apnea. Maybe about 10–15% of my patients are using sedatives, usually zolpidem these days, explicitly to improve sleep quality after breathing has been, and we do a quick trial of it and it's really making them feel much better. I tell them, okay, here's a choice. You can either stay where you are with some suffering or take whatever unknown risk there is of using a sedative for the rest of your life. It's up to the patient to decide what they want to do with it. Some patients will have little bursts of periodic breathing, but largely stable. I'll leave it be. But if they're symptomatic still, waking up at night, not waking up refreshed, as long as you have unstable breathing, that's the elephant in the room. That has to be kind of addressed.
Am I understanding you correctly though that your position is that some patients, even after resolving as much unstable breathing as possible, and even still, perhaps even on some low dose medication, still are going to have bad sleep? Or in other words, do you have some patients that they're just not resolvable? And if so, what typically is that? Or is it, do we just
so
have
the most
not know?
common patients with atrial fibrillation. So we have a atrial fibrillation sleep program. Before ablations, we get patients. And patients with atrial fibrillation sleep really badly, similar to heart failure. Their sleep is very fragile. You can also get something similar to that if you have, severe PTSD, anxiety, not fully treated or hard to treat. Their sleep is very fragile. So you can see, like conventional numbers, there's more stage 1, efficiency is a bit low. They have wake after sleep onset and so on. And, just fixing breathing is just the start. It's not the end. It's just the start. Periodic limb movements. Increasingly, I've been using intravenous iron to treat patients with what I call disruptive PLMs. They may or may not have restless legs. I don't care. But if there's a lot of motor activation during sleep, despite throwing everything we can for the breathing, it's likely a biological noise, if you wish. It is implausible that you can wildly kick your limbs and sleep undisturbed. It just doesn't happen. There again, the ASM has gone wild because they want you to not score limb movements when there's abnormal breathing anywhere in the vicinity. That makes no sense. You should be scoring whatever is there and then trying to figure out, is it important or not? Not ignoring it so that you don't know how much is there, right? But ultimately, if you have persistently high loop gain and periodic breathing, either long cycle with heart failure kind of stuff or short cycle, it's not going to go away unless you were very hypoxic to start with, and resolution of the hypoxia slowly resolve the loop gain. But if you're not very hypoxic to start with, it's probably genetic, which means you're going to have unstable breathing, unstable sleep, regardless of keeping the airway open. So you have to do something to stabilize the rhythm of breathing. Body positioning is the simplest thing to do. If you sleep on your back, there is more loop gain. So side sleep is really quite useful. And then not using too much pressure, just going higher and higher on the pressure.
Sorry, can I interrupt? I didn't quite get that. Did you say sleeping on your back will not result in loop gain, or are you saying it is worse for loop gain?
Will increase loop gain on the back.
Okay.
Always. So side sleep is really important. Most of my high loop gain patients are on like 8 to 10 centimeters CPAP. That's it. I'm literally trading off maybe some mild obstruction REM sleep so that I don't overventilate in non-REM sleep. Some patients will need, real pressures in REM, but the majority, they have the disease mostly in non-REM sleep, so they don't need much pressure. And I use acetazolamide. I mean, they behave like they're at high altitude, basically. So at high altitude, what do? You take Diamox. So that's what we do, but we use small doses, like 125 milligrams. That's it, just a tiny dose. And then we use non-vented mask configuration to allow a bit of CO2 rebreathing and stabilizing CO2. That goes a long way. Despite all of these, some patients, they're better, but they're still, impaired, and then they end up on daytime modafinil and so on. So we don't give up on our patients, and we use multimodal therapy in a lot. Not just here's your PAP or here's your oral appliance and goodbye. I use Diamox with oral appliance. I use Diamox with Inspire, oxygen with Inspire. Oxygen's problem is getting coverage is based on low saturations, not based on breathing rhythm. We have worked out a deal with our local home care company for a $75 a month rental, so patients can try it out for a few months. And if it's really helping, they can decide to either keep renting or buy a machine outright. But oxygen is idiosyncratic in the sense that the dose of oxygen you need to stabilize breathing rhythm consistently is too high. You can't use 60%, 70% O2. So the doses we use, like 2 to 4 liters a minute, about 20-25% of patients will have a really good response. The rest, it may look better on a sleep study, but not enough to make a tangible clinical difference. So you have to embrace multimodal therapy if you're dealing with anything other than REM dominant obstructive sleep apnea. The REM dominant, nice big V-shaped desaturations, and CPAP just works great. Or just keeping the airway open. That's all you have to do. You don't have to do anything much else. That's just about half the patients. The other half, you have to really personalize it much more than that. So yeah.
Can I bother you to tilt your camera down a tiny bit if possible? Is that possible?
Down?
Yeah, just a little bit. Tiny bit up. That was a little bit overcorrected. Yeah, that's good right there. Perfect. So how do you know if you Well, if you're seeing either short or long cycle periodic type breathing, how do you know or what to choose among the treatment modalities? Whether you go with acetazolamide, oxygen, the EERS, or ASV, how do you decide that? Is
Well,
that
ASV,
data driven,
yeah,
or is there probabilistically one that's typically more resolving than
yeah.
others?
So short cycle does not respond well to ASV. ASV is a design for long cycle periodic breathing. So short cycle right away, ASV is a bad idea. There's actually some data published. I can't remember who did it, but they did ASV at high altitude periodic breathing. They could make the numbers of breathing stuff look a bit better, which is sort of cosmetic almost, but sleep quality was no better. Not surprising because the ASV algorithm is not designed for rapid change. It's designed for slow oscillatory change. Uh, Non-vented mask, ERs, that really is the safest, simplest thing to do. The CO2 doesn't go up, it doesn't go down, it just stays where it is. That's what we want. We don't want it to go around. We just want it to not go down, basically. And that's the first line. And it combines, it's very additive or even synergistic with low-dose acetazolamide. So what we do in our lab nights is to, for these patients, is to, well, if they get to the lab in the pandemic times, our lab was closed fully for maybe 4 months, and then we did only diagnostic studies for a while. So about 6 to 7 months, I had no lab titration, but I used dead-space Diamox, and I had a couple of hundred patients treated that way. And they're doing well enough that they don't want to come back to the lab. So that's okay. But if you can, so after a home sleep apnea test, if a person has very overt high loop gain features, I will start them on non-vented mask right away. I'll explain to them what's going on. Patients have no difficulty with this. They just want to understand what's going on, and they don't care on label, off label. They don't really care. They just want to feel better, right? So short cycle periodic breathing, acetazolamide is quite useful. But non-vented mask is devoid of any side effect except the mask being a little tight. Acetazolamide, there's a non-zero risk of renal stones. Even that small dose, I have like 3 or 4 patients who developed kidney stones. And this is without any family history of it, no obvious. But it took them many months to do so. 2 patients had developed crystalluria, meaning the moment they started acetazolamide, the urine became dark and cloudy. They had microcrystals. So the urine was probably having a lot of oxalate. So when it became a bit more alkaline with acetazolamide, oxalate started precipitating and urine became cloudy. So we can't use acetazolamide then. Zonisamide is similar to acetazolamide, but patients who somehow can't tolerate acetazolamide, like 125 milligrams, we can use 25 milligrams of zonisamide. And there are a couple of papers on buspar. One is in spinal cord injury patients, one is on heart failure patients. This data, the heart failure data came from Europe, showing improvement in Cheyne-Stokes respiration. So we have been using buspar when we can't use acetazolamide. Either creatinine is too high or they have sulfur allergy. And the data is, our experience is much less. We have hundreds and hundreds of experiences with acetazolamide, but buspar is maybe 20. It does seem to help, but I don't yet know what's the right dose. I'm just using 15 milligrams at bedtime. Not sure what the right dose is, or how to even test whether it's effective or not. Acetazolamide works very quickly. So we can literally in the middle of the night wake up the patient, ask them to take the pill. And you'll see within half an hour to 1 hour, you see the effect. The buspar, I don't know whether that is true. So I haven't quite tried that yet. I usually start it at the beginning of the night. So anyway, it's still a learning curve for all of us in these things. Many patients have true mixed physiology. They have obstruction and they have high loop gain. So you do have to deal with the obstruction. I'm looking forward to availability of the GLP medications. Patients who have, where the obstructions interfering with treatment. That is, you can't get rid of the obstruction before you end up having central features, and it's just a bad mix. By unloading the airway, hopefully the treatments will work better. Right now we say, well, try to lose weight. Of course, they come back 6 months later, it's gone up by 3 pounds. That's unfortunately more the reality. But with the GLP drugs, hopefully, selectively, we can optimize patients by unloading the unstable system a bit. So we have to mix and match and personalize. All those who go around giving talks and writing articles about personalized sleep medicine, I know for a fact that in their own labs, all they do is throw CPAP at people. So talk is cheap.
You mentioned earlier that about 50% of patients respond to the catch-all treatment of CPAP, and 50%, let's say, require something else. How many patients would you say have not necessarily like a very obvious phenotype of complex apnea, but patients who you believe requires like beyond CPAP and then also something to treat loop gain? What percentage of patients do you feel, or I don't know if there's literature that's published that shows the prevalence?
There is about 30%.
It's about 30%?
About 30% have expressed high loop gain. That's, you can either mathematically or computationally or non-REM dominance, like about 30% of all comers apnea is clearly higher in people with some diastolic dysfunction or atrial fibrillation and such, but it's just all comers apnea. About 30% have unstable breathing control. And this is based on Andrew Wellman's data, my data, Safwan Bader. I mean, anyone who's cared to look at it, we find the same, roughly 1/3, where there's enough loop gain to be a problem, enough elevated loop gain to be a problem. The others who are sort of borderline and they do okay. And the less hypoxic you are, the more in trouble you are, because it means that hypoxia was not the driver. So even if you use CPAP, it's not going to resolve the time.
Interesting. So, I mean, in that context, then, I mean, there is an absolute disaster on our hands with respect to what the general sleep physician is saying and doing with their patient, right? From my perspective, the vast majority of clients and patients that I've had the opportunity to speak with, almost none of them will say that their doctor mentioned anything related to loop gain. And then if there's any central, it's just automatically ASV. That's all they really think about, right?
And you got to have a lot of central, not just, Yeah, the problem with central is that it's the tip of the iceberg, right? There was an era before my time in sleep medicine when only apneas were counted, no hypopneas. And Medicare had this rule. You got to have 30 apneas. It was called the 30 apnea rule of Medicare. If you didn't have 30 apneas in the recording, Medicare would not cover you. So then Medicare then went to add the 4% desaturating hypopneas. Not that it made it much better, because people high loop gain, because they tend to overventilate, they tend not to desaturate. So it's sort of ironic. They just don't have much desaturation. So if you use the 3%/arousal criteria, in fact, I just read a sleep study where the AHI 3%/arousal was 44 and the AHI 4% was 3.1. Does a person have apnea? Of course they have apnea. But Medicare says, nope, you don't.
Unbelievable.
So, when I first started throwing these ideas around, I was still a fellow, actually. And then, at that time, there was much less scientific data in this area. So I can understand some skepticism and all that. But if we put together work by Jerome Dempsey, Safwan Bader, Andrew Wellman's group, the stuff which I published, and Atul Malhotra and Chris Schmeckel. Schmeckel was my fellow out here too. I mean, it's overwhelming evidence well, overwhelming data. To use the word evidence, you need to have randomized prospective studies and so on. But overwhelming data that the endotypes are important. And there is this study starting at Yale. I'll tell you what it's called. Give me let's see, how do I find it quickly? PubMed. That's a cute acronym. NICEPAP, NICEPAP. Okay. So this is novel physiologic predictors of positive airway pressure effectiveness. Okay. And the idea is to basically endotype people and start them on CPAP and see how the endotypes change outcomes. So it's not an intervention study. It's a physiologic observation study. And this is just the protocol published in Sleep and Breathing. And I think Andre Zunchuk at Yale, he's the guy behind it, but basically Scott Sands, Wellman, etc. I couldn't actually, even if they asked me, I would not participate in the study because I've gone beyond this a long time ago. More than 20 years I've been targeting endotypes. And initially in the early 2000s, I tried getting grant funding, NIH, etc. The reviewers didn't believe this was a problem. They just absolutely refused to believe that this interesting grant was striking a problem that was important. That's how the reviewers were. Like this, yeah, this is like a well-written grant, blah, blah, blah. It's not clear this is a problem. And I've moved on to other things. So, but now I am working with industry to get the stuff to patients, ERS and all that. So give it a couple of years, I think we'll be in much better shape. And we have a software which measures self-similarity, so basically periodic breathing, which one version of it is already available freely, but we are patenting another one. I realized over the years that to really get to patients, you need industry behind you. There's only so much you can do as an individual academically. You can publish and get famous and all that, but to actually touch, just think of oncology. What would ever get to any patient if industry did not take an idea and run with it? So my goal is to try to convince industry, device industry, etc., to, I mean, they need to see obviously a business strategy in it, right? They're not going to do it for charity. But without that kind of drive, there doesn't seem to be enough drive from within the sleep field to want to change. So sleep is doing quite well with narcolepsy treatments. It's doing reasonably with insomnia, restless legs. It's doing but with sleep breathing, which is really the driving force of sleep medicine, you take away sleep breathing, we would not exist as a field. Just like you take away ischemic heart disease, there will be no cardiology. There will be all these side little gigs, but ischemic heart disease is the engine of cardiology. So sleep breathing is the engine of sleep medicine. But there is no angst about doing better. Angst from patients and people like you, but across the field. So perhaps it has to come from outside, industry, patients, rather than, it's not like the ASM is forming these committees saying like, we must do better with sleep breathing. No, they're not doing that. Just the reality of where it is. So anyone in the anywhere close to Massachusetts, I can help them for sure. But I have patients coming from out of state, and well, they got to pay their way, and sometimes the insurance will cover the sleep study, and they can buy the non-mint ERS supplies from one of our home care companies, and it's a very roundabout way of doing it. But yeah, I have patients in 20 odd states who have come just for getting the titration done and then a few of them have rigged up their own dead space. I tell them, maybe you should not do that. I should check check with me before you do that. But that's just how it goes.
So what can a patient at home do if they believe that they might have high loop gain or a loop gain issue? What's the easiest thing that they can do? Would it be to look at their Oscar flow rate or some combination of looking at Oscar flow rate and something else?
Just the Oscar patterns. They just need to recognize what is stable breathing. Looks like a belt, like a belt. When the flow trace looks like a belt, that's good. When it looks like a brush, that's bad. That's a simple way to think about it.
Right.
If it looks like a brush, not good. Looks like a belt, good.
Is it fair to say, though, that the flow rate in REM can be pretty regular to the point that it starts to look similar to some short cycle type non-REM breathing?
REM is more jagged, but the jaggediness would not be symmetrical. It'll be more irregular. And it'll come clustered at, reasonable intervals. Usually, if you do about like a 5-minute compression, you can see the rise, the symmetric rise and fall. And CPAP does fix OSA. So if you're at reasonable settings, so if you're using treatment which will reasonably treat obstruction, what remains is not obstruction. It can be unstable sleep. It can be unstable breathing control. It can be high leak, and high leak you should be able to figure out. So if it's not leak, if it's not obstruction, that leaves you with fragile sleep or high loop gain. And they sort of interact. And what you can more readily target is high loop gain. Fragile sleep is a little harder to target because besides just a bit of CBT and maybe a little bit of sleep restriction, you're pretty much looking at using long-term sedatives and I would rather use low-dose acetazolamide at night than take Ambien forever. There is plenty of disorders where acetazolamide has been used for long periods of time, including periodic paralysis, diamox-sensitive ataxia, benign idiopathic intracranial hypertension, and so on. So glaucoma. There is some, I won't say comfort, but there is some familiarity with long-term use of acetazolamide in these conditions. But taking zolpidem forever, I would prefer not to do that. But if I had to take acetazolamide forever, I could more readily live with that. I won't be happy doing it, but at least more readily doing so. And you can't fix sleep without fixing the loop gain part. So you do want to stabilize loop gain. Your sleep may still need more fixing, but that's the only way to go. You have to stabilize breathing control. Body positioning is really not used adequately. When CPAP first came out, it had this god-like thing because of saving lives, the 80s and so on. The extreme apnea patients. Option was a hole in the throat or a mask on the face. It seems so much better having a mask on the face. But it picked up that aura that it can't go wrong. So if anything goes wrong, it's the patient's fault. That's it. The physician is never at fault. The treatment is never at fault. It's always the patient. So that legacy has continued because you get these flowery letters from the insurance. You're using it 4 hours, 70% of the time. Congratulations. The person's Epworth may still be 20. It says you're using it only 3 hours, 58 minutes. You're using it less than 4 hours, 70% of the time. So this is not medically necessary for you. So we take it away. It is beyond nonsense.
Yeah.
But that's the reality we live with.
Yeah.
And the ASM has somehow allowed it to come to this point. They could have preemptively crushed it, but they didn't. And now it's like a monster in its own right.
So do you think that the EERS device is going to be the most attractive potential investment opportunity for industry to get behind, or do you think it's something else?
Yeah, it's very simple to do and it's quite effective. But to get through the FDA, it will need a proper clinical trial, and it's not too difficult to do. But see, Philips, ResMed, etc., it will kill their ASV devices, right? So they have no incentive I tried for a long time to get them interested in CO2 regulation, but it was, some of them told me directly, like, this is directly competitive with an ASV device. And we don't have, really don't have a strong third individual. Now, it's all ResMed thanks to Philip's, stumbles. But ERS is, Dead Space idea has been around for a long time. The only different thing I did was to combine CPAP and Dead Space. That's all, But otherwise, the idea of using Dead Space to stabilize CO2 and sleep and central sleep apnea has been around for decades. Well, ever since Cheyne-Stokes was described, we know that giving CO2 helps stabilize, but that is too high. But when you support the upper airway, the CO2 change you need is almost undetected. It's almost nothing. The main effect of ERS is to prevent the hypocapnia during the arousal-related ventilatory blow-off. When you arouse, you always have large tidal volumes, and that drops the CO2, and that sets off this whole unstable sequence. So you're providing essentially a CO2 shock absorber. That's what ERS is. You don't want it to go up or down. You just don't want it to overshoot. And if you don't overshoot, then you don't undershoot. Don't undershoot, then you don't overshoot. So the system simply gets more stable. But sleep has to be decent. If your sleep is too fragile, nothing targeting breathing will be adequate. Will help, yes, but won't be enough. And we see this regularly in patients with Parkinson's, anxiety disorder, atrial fibrillation. Atrial fibrillation, because we have this kind of program, we see a lot of atrial fibrillation patients. And heart failure. We don't get too many referrals from heart failure patients, but they really can have pretty fragmented sleep. Stroke also.
I see this signature and flow rate all the time. Not all the time, but it's in some percentage of patients. And what I see is, very normal flow rate. It's consistent. It's it's
stable breathing.
It's not hairy, but then stable breathing. Sometimes there's a tiny bit of flow limitation that can be identified on the tops of the waveforms. And then what we'll see is a large, basically recovery breath, just one. What I think is happening, I'd love to hear your take on this though, is that it's one of the PES signatures, and that I believe on average, the negative pressure of those breaths is higher than what's normal. And eventually, after enough respiratory effort, they kind of have a little arousal and reset, body, whatever, gives it a jolt. Does that sound right to you?
So transient arousals are normal during sleep. The key is what happens after the arousal. So if you have one large breath, two, and then you quickly settle down, that's probably okay. But then if you have a sequence of instability, that then becomes the problem. So that's basically, the issue.
I see. Okay. This is a bit of an aside, but some doctors speculate that a lot of the ADHD diagnoses are not some, mysterious, neurological deficit, but instead are attributable to sleep disordered breathing. Is that something you've thought on?
So the majority of patients who have sleep apnea don't have ADHD. Yet a subset of patients with ADHD do improve when any comorbid apnea is treated. So I think they probably have at least a genetic risk, and then you have an environmental condition which amplifies it. So that is the simplest way to think about it. However, every patient who comes with possible idiopathic hypersomnia at some point in their existence, ADHD has been considered. If you can't focus, attention, sooner, boom, you get ADHD diagnosis. Narcolepsy patients that come with an ADHD diagnosis. and I tell them, like, you probably don't have ADHD, they almost get upset. The diagnosis has some advantages today. You get accommodations and so on and so forth. But anyone who's sleepy will have ADD for sure. The H part is a little, harder to be sure of. So anyone who carries a label of potential for ADHD, you need to make sure they don't have hypersomnia, that they don't have circadian phase delay, extreme night owliness, and they don't have substantial apnea. A little bit of apnea, don't have to worry. If those things are clear, then it's probably genetic ADHD. Obviously, the patients I see are the ones where there's some sleep symptoms, so it's not a fair assessment of the situation. But you would need to do pretty large-scale evaluations to know that you've got to have the right control. It's going to be a very expensive study to do. Then you've got to treat them to show that the apnea made or didn't make a difference. But ADHD's fundamental criteria is that no other disease reasonably can explain. So if you have traumatic brain injury, you may have ADD symptoms, but they don't call you ADD. They call you TBI.
I see.
Similarly, if you are autistic, do you need another ADD label? I'm not sure that's meaningful, unless that gives you a justification to do a trial of stimulant. In the past, before idiopathic hypersomnia, have had oxybate as an expensive drug. You could not get an amphetamine for a patient with idiopathic hypersomnia unless you somehow gave them a diagnosis of ADHD also, which makes no sense. But you had to ask the patient, like, did anyone ever think you had ADHD? Yeah. All right. Past history, ADD. Boom. We get the dextroamphetamine right away. While if I said this person has idiopathic hypersomnia, they would say, there's no drug approved for idiopathic hypersomnia. Now I say a person has idiopathic hypersomnia, I'd like to use low sodium oxybate. They say, no, why don't you go try amphetamine first? It's all the money. I can understand why it's about the money, but that's how it goes.
So I'm trying to be mindful of your time. I'll try to wrap this up. From your position, when you get a patient, what's the most actionable data you want to see? Do you want to see the CBCT scan? Do you want to see a PAP test, the level 1 sleep study, Oscar data, all of it?
Or which kind of patient?
Any patient, I suppose, who's continuing to complain, who's on CPAP. What do you find the most valuable data?
So here's the catch with that. Patients who had persistent sleepiness despite good use of CPAP. The obvious thing is to make sure CPAP is working well. Once you've done that, so now you have a choice. Either to say, okay, you have this residual sleepiness thing, and you have the option of using modafinil, armodafinil, same thing, or solriamfetol, and you can stop at that. Or you can try to probe further whether they are capable of very long sleep, bringing them closer towards the IH kind of spectrum, or do a PSD-MSLT and see what you find. And you will pick up an occasional narcoleptic, but more likely you'll pick up, well, sleepiness, consistent with hypersomnia. And I don't do that unless there is a plan that if that is positive, we would go as far as using oxybate. If that is not part of the plan, there's no point in testing because I can anyway get modafinil, and if that doesn't work out, I can anyway get solriamfetol. So if the plan is not, if the destination of oxybate is not a serious consideration, in my mind, there is no point in testing further. I would just, treat the sleepiness. Of course, I would maximize the goodness of their breathing the best I can. So increasingly, we are discussing the option of PSD-MSLT or running a long sleep study. But some of these patients are, much older, and you talk about oxybate, they describe it and such, they say, nah, I don't want to do that. Some will want to go further, and we would do so.
What do you think that the direction or trajectory of this field is missing? If you had a recent MD grad with 150 IQ and they said, "Where should I plug in, Dr. Thomas?" What would you tell them? Where should they put their attention? What are we missing?
The single biggest mystery is why we sleep as long as we do. We have no idea at all. Why do we need 8 hours, 7 hours? Why can't we do with 5? The duration of sleep is something which is a total mystery. It's not that the field hasn't tried to correlate with brain size, brain temperature, predator-prey difference, and so on, but that's because that becomes important for a lot of conditions. Insomnia, of course, hypersomnia, and disorders of the brain where sleep will change from its original, whether it is dementia, TBI, neurodegeneration other than Alzheimer's, epilepsy, all of these, sleep duration, not knowing why we sleep as long as we sleep and what that actually means is problematic. We don't know why rats and mice don't sleep more than they do, or elephants sleep. Why do elephants sleep so little compared to humans? Some monkeys sleep like humans, some monkeys sleep very fragmented, less than us, and so on and so forth. So it's this mystery of sleep duration. We have a decent handle on many things about sleep, but not the duration of sleep. And that's why for hypersomnia syndromes, idiopathic or otherwise, we actually are quite floundering without quite knowing what drives it. Just don't know. That's the last frontier of complete ignorance. Lots of ignorance in other frontiers, but that's the last one.
Now, are you interested in having patients reach out to you, or are you busy? Right.
No, we are very busy. But if they shouldn't be reaching out unless they can actually come out here.
And
Yeah,
where is
otherwise
here? What center?
it's Boston. If they can't come out here, sure, I know they can send me an email. I'll politely tell them, like, you got to come out. But that's the bottom line. We if someone has ongoing symptoms, hypersomnia, I mean, what will be their badness? Certainly, we can't do much better if the person has straightforward apnea. But we can do better if the person has high loop gain. We are pretty good with hypersomnia, though, again, most people can deal with hypersomnia reasonably well. I have a circadian disorders clinic, so people with circadian rhythm disorders, we can, non-24 and such, we can do better than most. But our most unique offering would be a more precise management of sleep apnea when a person has not done well with the convention, which will work 50–60% of the time quite well. And that I can't do any better, like anyone else. Same thing.
Last question. What do you wish that the general sleep physician understood? What would resolve a lot of the issues? Well, what are they missing?
They had to
Above all.
follow the science. They had to practice best science sleep medicine, not best evidence. There isn't enough incentive to generate evidence. So imagine in cardiology, if there was no new stent, no new anticoagulant, there'd be no clinical trials in cardiology. So with sleep breathing, the GLP drugs is the SURMOUNT OSA study is the one study which perhaps will change clinical practice. But every CPAP, every PAP-based study has been a dud. And if Philips sponsors a study, I could use a res-vent device, not even res-ment device. It's The skills are generic. Estazolamide is generic. I mean, these things are all generic. So a lot of questions in sleep breathing are unanswered or unanswerable unless the NHLBI decides to spend $100 million a year just on sleep apnea clinical trials, and they've already burned their fingers so much, they have no interest whatsoever in doing that. And industry has no incentive because industry can't recoup their cost.
Could you quickly double click or expand on the GLP drugs and the importance of them that you're alluding to?
I mean, you lose weight if you can keep using it, you lose up to 15-20% of body weight. And if, I mean, hypoxia is always improved, but breathing control will not be. And if you have a narrow upper airway, you're still stuck with it. So I have some patients, maybe a dozen patients who had GLP therapy and lost a good bit of weight. They come back for a sleep study. The apnea is better, and the more loop gainy problem they have, the less benefit they have. But almost all of them, when they sleep on their back, the apnea is back. Not as much desaturation, but they're pretty bad obstruction. That's just the anatomical component, which GLP will not change. So it'll be beneficial. It'll be a nice additional therapy, but to think it's going to wipe out CPAP is stupid.